All right, thanks, Joel, and thank you for allowing me to clean up here at the end of the excellent symposium.
That's right.
Actually, really educational for me, and happy to speak. I would have to say this is not a dangerous talk. We're playing it very safe, though it could be provocative because a lot of the information here you probably are familiar with. High points of therapy for patients with psoriasis, development of therapeutics, but maybe I'll just interject some of my opinion about what some of these therapies mean. I'll be talking about basically 4 therapies that are maturing. Now, my perspective on psoriasis therapy currently is we're kind of entering into a late adolescent phase of developing therapeutics in that the age of biologics is fully mature. I don't know if we're going to see new biologic therapies for chronic plaque psoriasis being developed because we might be hitting a ceiling of efficacy with IL-17 and IL-23 inhibition. And the concept of now combination therapies will move forward like Artie just talked about, or dosing like Andy is fond of talking about. Those are going to be the frontiers for biologic therapy, but not new therapies. There's one, though, that I will talk about in this session because it's relatively new to the United States, but not the rest of the world. So IL-36 receptor antagonism, particularly Spesolimab for the treatment of GPP. But we're going to go back to flare prevention instead of treatment of flares. TYK2 inhibition. And that speaks to now where we're moving with therapeutics in psoriasis now with orals. A lot of attention on oral therapeutics from a variety of companies. And there are going to be winners and losers in this phase of therapeutic development. And one of the winners might be this oral peptide that blocks the IL-23 receptor. And we'll talk about the data there. And then PDE4 inhibition, which is not going away. There are a variety of companies that are trying to develop the better PDE4 inhibitor that goes beyond apremilast. So we'll talk about that. So first, Spesolimab, quickly. Not a new drug anymore, IL-36 receptor blocker that's indicated for treatment of flares. As an IV formulation, you treat flares of GPP. And that was demonstrated really in a landmark study which is impressive because of the rarity of this disease and the ability to enroll so many patients around the world and show demonstrably that, as you can see here, patients who get one IV dose have a rapid resolution of their disease, the majority of them. And it doesn't matter what their severity is at baseline. So we know this drug works for flares as an IV, but what do you do? The other half of this drug is missing. Like, what do you do to keep people in a normalized state who are prone to flares? They're not flaring now, but they're prone. And I think the company that makes this drug understands that the next phase of development of this drug has to involve flare prevention. So they embarked on another excellent study where they took patients at risk for GPP flare who aren't actively flaring and putting them on a variety of doses of a subcutaneous formulation of Spesolimab, multiple doses, and comparing to placebo, and basically over a year, 48 weeks, seeing which dose did the best. And not surprisingly, what's called high-dose Spesolimab resulted in, I would say, pretty much the elimination of flares over the course of that year, compared to lower doses in placebo at the top. So kind of a nice dose response, speaking to a Q4-week high-dose regimen being preventative. And so if you put out the fire, you can keep the fire out when you use the sub-Q. And that's what these data show. Now, the only caveat is other therapeutics off-label seem to work for GPP. And I think all of us who treat psoriasis know this. For example, traditional biologics, IL-23s and IL-17s, and even in my hands, can be effective. Are they still going to be the competitor for Spesolimab long-term because of their ease of access for psoriasis and not requiring IV formulation? So that's my one caveat to think about. Will the uptake of this drug match what's being used by off-label use of biologic therapies for psoriasis, chronic plaque psoriasis? And the second thing, the rarity of this disease means a lot of providers, not only dermatologists but non-dermatologists, don't recognize it. So will there be enough of an awareness to bring these patients in for therapy and actually effectively prevent future flares? All right, this is a TYK2 inhibitor that goes beyond what we already have. We have deucravacitinib, a very selective TYK2 inhibitor. In my opinion, presents a profile distinct from a typical JAK kinase inhibitor that we use for, say, atopic dermatitis and alopecia areata. This is a developmental program that builds on this program. Deucravacitinib, very important drug, FDA approved for psoriasis, which demonstrates better efficacy than not only apremilast but also a placebo at 16 weeks in 2 important studies, and then seems to get better at 24 weeks. But note the 12-week efficacy. I would put PASI 75 in the range of 45 to 50%. That's your 12-week efficacy. The reason why I point that out is there's a drug on the horizon in phase 3 which seems to have a 12-week efficacy in phase 2, better than what we saw for deucravacitinib, or 2 out of 3 patients, 67%, are at PASI 75. And therefore, the promise of this drug is it's a better TYK2 inhibitor. Does that mean it's going to win? We don't know, because the next drug I'm going to present may make this argument sort of a moot point, because there's still a lot of providers who don't prescribe deucravacitinib based on, in my opinion, an unwarranted fear that it's still a JAK kinase inhibitor, and we're just not seeing the other foot fall on the safety of that drug class, of this drug class, TYK2 inhibition, from a long-term perspective. I don't think the data suggests that it's another JAK kinase inhibitor. I think these are unique drugs that have a lot of potential, and particularly this might be a better TYK2 inhibitor. And we see its only adverse event of interest in its phase 2 was acne, which seems to be dose responsive, but you notice everything else in this table is zeros and ones. So really an uneventful mechanism of action from an adverse event profile, except for the acne. Now, this is the drug I alluded to earlier. It's an oral IL-23 receptor antagonist. It's a peptide, not approved yet, just given a name that's a series of letters and numbers, which they got to improve on, because no one's going to remember it until they give them a name, even a generic name. But right now it's called 2113 for short. It's completely novel concept because it's an oral medication that blocks IL-23 signaling by blocking the receptor. The only caveat has to be, it doesn't have to be, but it's going to be better bioavailability if the patient is taking it on an empty stomach. But it's not a big difference between taking it on an empty stomach, say 8 hours fasting versus just a half hour fasting. So it's not going to be as complicated as it sounds, but a full stomach does reduce its bioavailability a little bit more. And it appears to be targeting a once daily formulation in the long run. You're going to see twice daily efficacy is the best, but I think in the long run it's going to be a once daily drug. Perhaps the patient takes it first thing in the morning and you solve that empty stomach concept. And again, a very good study, multiple doses, a placebo, done over 16 weeks, typical psoriasis patients with moderate to severe disease, and really convincing data in terms of efficacy, up to 80% PASI 75. Appears to my eye better than the better TYK2 inhibitor, so we even have more efficacy out of an oral. 60% PASI 90 from an oral drug, which would make it the best oral drug we've ever seen. 40% PASI 100. And note, it's not a slow response. The patients are seeing response, 4 to 8 weeks in. It's dose response. You're seeing once daily dosing at some of the lower doses, like 100 milligrams daily might be better. 50 milligrams daily is better than 25 milligrams twice daily. So that's the same daily dose, but the 50 milligrams once daily seems to be a little better. So it speaks to once daily dosing is possibly as good or better than twice daily. And then the adverse event profile, a lot of numbers here. Just let me summarize. There's not much going on. It looks like a 23 inhibitor for the most part. Maybe a little more nasopharyngitis is what you see with 23 inhibitors. So from a phase 2, at any dose, there appears to be a good tolerability without any alarming adverse event profile. And data not shown here suggests that out a year, this drug at any dose maintains efficacy. So we don't see a loss of efficacy over time, which we don't see with 23 inhibitors in general. They keep the response over time. So this seems to be behaving like a 23 inhibitor, even though it's an oral formulation. So I think that's a very promising drug that potentially can upend the biologic market in the long run. And then there's this final drug I'll talk about, erismolast. And I don't think it's the only PDE4 inhibitor being developed orally in the world. There's a few other companies targeting PDE4, but I'll use it as a paradigm. Maybe a better PDE4 inhibitor from an efficacy standpoint than apremilast. Now we have to contextualize development of PDE4 inhibitors. There's a generic option of apremilast coming in the near future. When apremilast goes generic, whenever around the world, we're probably going to be forced to use it, and it might be very inexpensive. So a novel branded PDE4 might have trouble in these markets with generic apremilast around. I like this drug in the first place because they did a mechanistic analysis of how this drug, erismolast, may affect commonly cytokines that are ascribed to be relevant to psoriatic pathophysiology, and how at baseline IL-17A is knocked down after 16 weeks of treatment with erismolast, or TNF-alpha knocked down, chemokines knocked down, and finally IL-23 expression. So like we've always been told, PDE4 inhibition somehow treats psoriasis, probably because it lowers expression of key cytokines that are relevant to psoriasis pathophysiology. And here we see it mechanistically. Erismolast does it. And maybe erismolast is more potent, as you'll see in the data I'm about to show, because it blocks the relevant isoforms of PDE4, B and D, more effectively. So here's their elegant study, dose finding, 20, 30, and 40 BID versus a placebo, 16 weeks. And just note, PASI 90 responses are being read out. That's not typical for PDE4s. And you're seeing about 1 in 5, 1 in 4 patients get the PASI 90. Why does that matter? Because apremilast has about only 1 in 10 patients get to PASI 90. So this may be a more potent PDE4 inhibitor. Now, what I'm not going to show you here is the tolerability issues associated with PDE4 inhibitors still appear with this drug, namely GI intolerance, nausea, vomiting, nausea, diarrhea, and some headache. And therefore, I think the drug dose we'll look at is 20 milligrams because it seems to have decent efficacy in the lowest tolerability issues. But we're never going to get away from PDE4 inhibition causing nausea, diarrhea, and headache. I just don't think it's out there. So we're going to have to tolerate maybe a better efficacy, but still intolerance. And I'll end by saying, where do I think PDE4 inhibition belongs? I still think they're going to, in my shop, be adjunctive. And people who are having suboptimal responses with skin or joints as add-ons. Even though the companies that make these drugs want them to be monotherapy, I think in the age of high-potency biologics, maybe even higher potency orals, these are going to be add-ons, and that's great. Or maybe add-ons in other inflammatory skin diseases like HS, where I think PDE4 inhibition actually also shows some promise. A little skepticism on the overall place of this drug in the long run, especially at generic apremilast on the horizon. But I think we're not going to hear the end of the PDE4 inhibition story. So with that, I'll summarize: 36 receptor inhibition for subcutaneous formulation, prevention of DPP flare, TYK2 inhibition, maybe the better TYK2 inhibitor is on the horizon. This drug is highly promising, the IL-23 receptor antagonist that's taken as an oral route, and finally PDE4 inhibition. And I'd even speak to topicals. We obviously are having more topicals brought to the psoriasis market, which is very interesting, and that comes down to more about access. I think a lot of payers are not willing to splurge on topical formulations, but keep your eyes out for even further development of topical therapies. Excellent. Thank you very much.
Bruce, that was really a terrific talk, great summary of all the advances in the last year in systemic agents for psoriasis. We have about maybe 10 minutes left for some questions for Bruce and Andy, so I want to invite people to come to the microphone. While people are thinking their questions, I want to start off the discussion. So, it occurs to me, in thinking about some recent work Andy's doing, some of the work that Bruce has presented, is that maybe we're not dosing our drugs properly, right? Maybe we're underdosing people systematically, or maybe in some cases we're actually overdosing. People probably could stand to, be off their drug for a while. In Europe, there's been a lot of data emerging about on-demand dosing for biologics, just give them the loading dose, and then when the disease comes back or they have symptoms, start it again. There's also some therapeutic drug monitoring going on with adalimumab that helps them nuance how they dose a drug. Where do you see this shaking out?
Yeah, I'd like to comment first. So in general, in medicine, we have the dose of the drug, right? And higher doses of drugs in general cause more side effects. And so, and I think that is a paradigm we've grown up with. What's happened with the IL-23 drugs, though, which we didn't know when we were studying them in phase 2 and phase 3, is that these are P19 inhibitors I'm talking about. So we didn't know that they were going to be so safe. And they've turned out to be incredibly safe, and over 5 years of use now, lots of data. And what's happened in the adjunct field is that higher doses of these drugs are approved for Crohn's disease, and without any extra safety issues. And so the study that we've done recently, the knockout study, which I'll be talking about at the late breaker, used Crohn's doses in psoriasis patients in a pilot study. And we saw clearly 25% higher PASI 100 rates without any safety issues. And so it suggests that now with all this, some folks are saying, well, you want to prove that the dose is wrong and I think the dose was right when we were studying them, but now I would suggest maybe the dose is wrong for IL-23 inhibitors, and the idea that you need regular dosing. I think the old study of Remicade as needed, Remicade infusions as needed, told us that anti-drug antibodies developed, and you don't want to do as needed biologics, right? You just want to do them on the schedule. But with 23 inhibitors, I think it's different. You see people spreading out doses instead of every 3 months. You have people on their own doing every 6 months, every 9 months, and you don't seem to be losing efficacy or having an anti-drug antibody issue. So the combining the higher dose safety of Crohn's patients and combining sort of real world data that people are spreading out doses suggests that for that class of drug, maybe the better thing is to dose high and to dose as needed. That's my comments. But
Bruce? It comes into access. I've always felt a lot of patients are underdosed with all the MOAs, and I just can't get patients to get approved for higher doses, and it's all biologics. It's not just psoriasis. It's atopic dermatitis with dupilumab. A lot of patients, I think, need weekly dupilumab to be controlled, but we can't get that. A lot of patients need Q6 guselkumab, Q6 weeks. Some patients need Q10-week risankizumab, and I can't get that. So I'll come back to what Artie was saying. Combination therapies are highly appealing to me, and I think they can be done safely. And there's a variety of ways you can combine small molecules of biologics, 2 biologics together. My happiest patients are on combinations. Again, you got to get past the insurance barriers. There's tricks there. one for psoriatic arthritis, one for psoriasis, for example. That's one way to go.
Yeah.
And then you can get really high efficacy that covers all the bases.
I think that, in most chronic diseases of medicine, you start with a therapy and you add on.
Right.
Only in dermatology, we start, they do pretty well, and we give up.
Yeah, I know.
And we try something else.
It's crazy. Our whole paradigm has been wrong for years. Take a really hard disease, HS. Everyone in this room knows HS. It's rarely a monotherapy disease. I mean, you really always need 2 drugs minimally in an HS patient. Even then, you get failures.
Yeah.
Right, so.
Pranav.
Just a clarification and a question. First, there's a comment made about intermittent dosing. Do we have data beyond 1 year on the role of neutralizing or anti-drug antibodies? Because the data we have so far is looking at consistent dosing, but do we have data on intermittent dosing? And I say that because we are still slowly forced to accept extrapolation of the Remicade data and the other monoclonal antibody data, which we know there's an increased rate.
Yeah.
But are you saying that we don't have any? Because
No.
I'm not aware of any data saying that we're not getting an increased amount of neutralizing or
With intermittent.
anti-drug antibodies. I've not seen that yet.
Yeah, Pranav, that's great. I mean, you're right. I mean, the whole concept of a hiatus from biologic therapy is never really formally studied in dermatology like it was in like Remicade early on, infliximab. So we don't, and actually, if you look at whatever we do have, like Spesolimab, they don't show a lot of neutralizing antibody or even non-neutralizing antibody formation has relevance to their efficacy over long hauls. So it's even hard with the current drugs to even ascribe a risk of anti-drug antibodies to these drugs.
So have you seen the data out beyond 1 year with Spesolimab and their neutralizing antibody and
Not beyond 1 year, I don't think.
not beyond 1 year? So I'm saying is we don't have data
No.
available. I mean, the clinical is clearly we're not seeing the same amount of loss of response as we did with our traditional TNFs and maybe even some of the IL-17s. The second thing was very intriguing, Dr. Blauvelt, Andy, was when you mentioned these inflammatory fibroblasts, right? We're adding another paradigm in terms of the cellular matrix that's involved. Kebnerization, can you just comment? Because you mentioned fibroblasts. We've thought about kebnerization as a keratinocyte and immune cell phenomenon, communication. But you brought in the fibroblasts. Could you just comment on, is there anything about the fibroblasts in that situation?
I don't know.
Kebnerization?
Johan is in the room. I don't have any information about the single cell seq of a kebnerization, but
Or just a theory about how the fibroblasts might be involved. Okay, thank you.
All right. Well, with that, I want to thank Andy and Bruce for great talks, a great discussion. I want to thank you all for being a tremendous audience.